So what I'm talking about is I want to talk about framing, and it goes back to behavioral economics. A lot of times we spend, well, what are we going to say to the ethical committee? What are we going to tell our patients? And that's the way in which we do it isn't based on any theories or principles. And then I want to talk about the harm from informed consent and whether we can think about that as moving forward in ways to motivate things. Okay, so this is the classic example of framing is that, Sister Teresa is saying, the Mother Superior, I'm really pissed off. Mother Superior said that I couldn't smoke when I prayed. And, her friend Sister Maria said, oh, that's odd because Mother Superior said that I could pray when I smoked, right? And there's all sorts of examples of this that you can say things in lots of different, the same thing in two different ways. And our big problem is how we've been talking about ethics and TWICs, and I'm way more guilty of this than anyone is. What we've been saying is, if we change the ethics this way, or we do the randomization in a different way, it's going to help me as a researcher, right? We'll get more patients on trials, and I'll get a bigger study, and I'll be in the BMJ, and it will be great for me, right? It's this sort of selfish thing. And it's just generally not worked with ethical committees. When I've gone with them, and I said, look, it's much easier to do this. Now, I genuinely believe that a lot of the novel ways we have of thinking about consent and thinking about randomization and doing things differently in terms of the consent are actually better for the patient. Okay? Now, if you remember this, do you remember this film, No Country for Old Men? This is an absolutely terrifying scene where this psychopath goes into and says, call it heads or tails, and if you get it wrong, I'm going to kill you. It's absolutely terrifying, right? Everyone remembers that. But I mean, this is just like, every day at Memorial Sloan Kettering, this is what we're doing. We're saying, well, we're going to flip a coin, and you're either going to get surgery or you're going to get the therapy. To help you decide that you've got a 17-page consent form. And it goes on. I mean, there's 4 pages of risks like this. Right? This is a completely traumatic experience from a patient. And what was interesting? I got a friend of mine who's a general practitioner, and I asked him, tell me, do you have any patients on trials? And he says, what happens to me all the time is I have one of my patients, they're dying of cancer, they get involved in a trial, and they come back to me, and they're devastated because after all this crap that they go through, they get randomized to the best supportive care, right? Which means this is what happens. You've gone through your chemo, the cancer's still growing, we're either going to send you home to die, best supportive care, or you're going to go on this new exciting agent, right? And they go through all this hell, and they're bitterly disappointed. It's really, there's a lot of problems, a lot of distress. It goes on and on and on, by the way. So we're asking patients to make this decision, do you want to go on this trial or not? And that causes cognitive burden. It causes conflict, what should I do? That induces anxiety in patients. They're worried about now what to do. Then you get something called decisional regret. You've made the decision to go on the trial, and maybe that was a bad idea. Or the worst thing is, look, I just can't deal with the trial anymore. And then you're thinking, oh, geez, maybe I should have gone on that trial. And then there's this aspect of confusion. You say, well, I'm really come to terms with my situation now, doctor. I know my life is short. I really want to spend it with my family. And then they come along and they tell you about this fantastic new drug. I'm like, well, great. Why don't you give it to me? And like, oh, well, we have to do a randomized trial. And that's very confusing for patients, right? Why, you could save my life with this new drug, but you're not going to give it to me. And then this issue about disappointment that, okay, I didn't get the new drug. Now I'm very disappointed. This was my one chance to save my life. And all of this is in this context of extreme information overload. So we're often doing these trials at this terrible time in a patient's life when all these other things they've got to deal with. I do surgical trials. Patients have just been diagnosed with cancer, and we're telling them about their treatment options. And if they choose surgery, there's a 78-page booklet about catheter care and wound care and coming off Coumadin before. And we're asking them, and then on top of all that, we're giving them this 17-page consent forms. And my own view is that there's an idea that the more information you give people, the more informed they become. I think after a time, then it ducks down again, the more information you give them. And patients, I don't know what your experience is in the consulting room and watching patients, but it tends to be after a certain point, they're like, it's just too much. I just don't want to deal with it. Or look, hang on, just doctor, what do you think I should do, right? It actually causes a regression with less autonomy when you give all this too much information. So now let's look at a typical design of the sort of thing that we're doing is that you're randomizing the eligible patients, and if they're in the control group, you just say, well, I'm going to give you the surgery, and here's your consent for the surgery. But if you you randomize to the neoadjuvant therapy, well, we've got this new treatment. Would you like this new treatment? And then they get the research. They get a research consent as well as a clinical consent. What happens if you do that? Well, the thing about making a decision and all that burden and anxiety, and should I go on the trial or should I not go on the trial, and all that is reduced by half, because half the patients are never having to face that sort of decision. The information overload is reduced by 50%. Because what we're doing is we're sitting and explaining all these side effects to patients, on and on, and well, what do you mean diarrhea, and on and on, and 50% of the patients are never ever going to get subject to that side effect anyway. And then, of course, confusion, why can't I get this treatment? And, oh, now I'm really disappointed I didn't get it. You're eliminating completely. So this is an awful lot of patient distress that I think you could eliminate by changing the way we think about doing consent. And so we can reframe this whole thing. So I genuinely believe doing this sort of trial is going to relieve a lot of distress amongst an incredibly vulnerable population who, frankly, have got enough on their plate. I mean, look, I come from the cancer world, so I know there's probably similar things in some of the other diseases that you guys deal with. So can we reframe it like that? There isn't very much, the problem is there isn't much empirical data. I'd love to say, oh, look, here's all this data showing that standard consent is very, very distressing. So this is going to be an empirical base for saying we need to think again about distress. This is pretty much it, this one trial in the British Medical Journal in 1986. I don't know, there's a variety of different endpoints here, but one of the interesting ones is the anxiety. This is the state trait anxiety inventory. Does anyone know that scale? These are incredibly high, right? And if you look at the difference between the two, I mean, and this is just by changing the type of consent, you're actually causing clinical anxiety in a very large number of patients. So this is what I put in a grant to do. I'm planning to do it. If other people are interested in this type of research, let me know. Let's talk to patients who've been approached for participation in a trial, whether they took part or not. And we do the focus group, and we have qualitative researchers. Where was our qualitative research? So there you go. Talk to them. Tell me about it. Did it make you depressed? Were you anxious, and so on? And we design some kind of survey instrument, and then you do your standard psychometric study when you evaluate the properties of that instrument. So, does it distinguish between a trial in end-stage cancer and a trial of, music therapy for mild depression or something? I don't know. You'd expect there to be different levels of anxiety associated with those two trials. So what I hope to do is say, let's reframe this debate as something, let's do this research because it is actually better for the patient and because I actually genuinely believe that to be true. But we also need to document that. But where are we going for this? Can we use harm to motivate Twix approaches? And I'm a little concerned about that because I believe that we could reduce the distress, we can reduce the harm and still maintain patient autonomy. But I think many in the US, there's this incredibly expansive view of patient autonomy. Unless you're telling the patient absolutely everything about everything, then you're reducing their autonomy. And I think that the classic example of this is that you've got these 17-page consent forms, which I think are brutal for patients, and that's seen as good. And if you say to a patient, I'll give you $5 for filling in a questionnaire, that's seen as kind of coercion by many. So I think I think there's going to be two battles we're going to have to fight, right? One is to demonstrate that there is harm and that it can be alleviated. And secondly, to actually say this is a bad thing. Because I've had people say to my face, or in written communication, ethicists say, that pain and suffering from patients, that's just part of life. And there's nothing we should do about it, because that's just being a responsible and rational human being. But anyway, I really appreciate comments on that, all that.
So, for the sake of time, I think we're going to go for three, in this case, three comments.
I think that the disappointment, I think this is really interesting. And I agree. Huh?
Can I get your number?
Of course, yeah, no. This is super, super interesting. I think that there may be a way to do this, but I'd have to know some more details. For instance, the disappointment issue, I agree with all the burden stuff, and just reducing all that except the disappointment even would be a tremendous advance. Right. The problem that you're going to run into is that if you do this with only cohort consent, or no cohort consent, and then we get back to the Zalen.
No, I'm not thinking
okay.
about that.
If you do advanced pre-randomization, whatever, there's going to be a certain amount of disappointment because they're going to know. I mean, look, if I'm going to go to Memorial Sloan Kettering, if you never call me for a trial and I don't have much time to live, I mean, I'm going to be pretty pissed, right? So I think that part, it's going to be very difficult to get around. However, I do think that there's something, it's a softer landing perhaps, right? If you don't go through all that and then told, well, you get the regular treatment, versus just not being called up to do whatever. And then the rest of it is you can argue for a pre-randomization broad consent. It spares the people of all that stuff. Yeah. I think you could make that argument.
Yeah, I take your point, but what we could do in a Twix context is, will there be another trial which might be a drug to help end of life anxiety, right? Or they wouldn't be eligible or something, but it certainly reduce it.
There's room for one quick comment.
All right, my next meeting's at 5, so I'd really like you to stay and chat to me afterwards.
Some of this during the panel discussion.
Yeah.
This is an ethical issue. So one more comment.
Yeah, I'm sure you've already realized that there's also a way to remove 100% of the suffering.
It's not a trial.
No, which is not asking anyone ever.
Yeah, but then that doesn't maintain the autonomy. I'm saying, can we reduce a lot of that suffering and maintain autonomy? If you think of a way of reducing 100% and maintaining autonomy, please let me know. Right?
That's a very good point for the discussion, panel discussion that we have. Okay.